Can you see my screen?
Yes, we can. Please go ahead.
Okay, full screen. Okay. First of all, I would like to thank you so much for the invitation to participate in your prestigious meeting. And it's about time that we meet in person, and hopefully we are getting there. So what I would like now to share with you our experience with managing decentered and tilted suture fixated IOL. And as we know, sclerofixation is a leading technique for cases with no capsular support. However, with two-point fixation, we may experience two complications. One is decentration and the other is tilt. So let's see the video. This is a patient with a very large cornea, it's a megalocornea, an unstable crystalline lens, and he had a very high astigmatism. So we planned to do toric lens. So here's the patient. We can see how unstable it is. So the decision was to do an ICCE and to remove the entire lens. So I make a large scleral tunnel and open the eye, put anterior chamber maintainer, and glide underneath the lens. So then with just a little pressure, the lens that will come out is one piece quite easily. Then we close the wound and we do the vitrectomy. And the lens that we decided to implant in this case was a one-piece Equisoft toric lens, suture fixated with a ProLens 6.0 and adjustable flange technique. So we pass the suture through the optic junction right through the lens material, and note that the lens is inverted. So the flange would be now at the back of the IOL once it is in the eye, away from the iris to prevent the chafing. So now we create the second flange, and then we insert the needle, the 30-gauge needle, at the axis of the fixation for the toric lens. So everything goes quite easily and smooth. Now we do the same on the other side. So all is left to do is to put the lens in, pull the sutures from both sides, make flanges, and actually we are done. However, as we inserted the lens inside the eye and pulled the suture on both sides, we saw the lens is tilted. And the more we pulled it, it was even more tilted. We can see that the flange is indeed at the back. And I tested again and again to make sure there is no twist, there is no rotation of the optics, everything seems to be fine. But the lens is very, very tilted. So what do we do now? We cannot leave it as is. How can we refixate the lens? Because as you see, we cannot get it straight. So my solution in this case was to do a third fixation. And I'm using for this third fixation a 9.0 ProLens, which I will fixate perpendicular to the long axis of the lens. So the needle is inserted perpendicular to the haptic axis, then I penetrate through the lens material, directly through the lens material. And I'm showing it the way because we did it in many cases in which we suture fixated through the lens material in eyes with hydrophobic lenses, hydrophilic lenses, and even silicone lens. And it works in every time with soft lenses. The suture is now, the needle is inserted through a 27-gauge needle and out through a paracentesis. We need the second end to make sure there's some counterforce. Reinsert the needle now in front of the lens, and suture goes a needle through a needle and out. Now we need to make sure that the 6.0 ProLens, we have the flanges, temporary flanges, so the suture will not go in. And now we suture the 9.0 ProLens, and we must make sure that this is not overstretched, otherwise it may decenter. We just need to be a positional and low tension, and we can even bury the knot inside the sclera. And now cut short the 6.0 ProLens on both sides, adjust the tension so it will be just on the at the center of the eye. And this is at the end of the case. The IOL is right on the axis of the toric lens, and it is stable in the plane of the iris. And this is another case of unstable IOL within the bag. And to fixate it, we use the 6.0 ProLens in a way that we do it routinely. We insert the needle behind the optic and out again. And then the second one goes in front of the optic. So this is how we fixate it on one side, and we do exactly the same on the other side. We must make sure that the insertion is done exactly 180 degrees. However, in this case, we see the lens as we pull the sutures on both sides is not centered. And actually, we have an element of the optic within the visual axis. So how do we recenter it? The solution in this case was to create a separation between the capsule and the optic to create a pocket, and then insert the 30 gauge needle in between the capsule and the optic and penetrate through the equator and out, and use the 6-0 Prolin to fixate the capsule to the sclera. The suture is pulled out on one side. Now we insert the needle in front of the capsule, and the 6-0 goes into the needle and out. So now we fixate the capsule to the sclera, and it is strong enough since it does not support the lens. It actually just supports the positioning of the lens. So now we cut short the suture, create the flange, and the case is done, and the lens was quite stable. And as we can see, we have two types of fixation. One goes around the optic, and the second one here on the left is fixates actually the capsule to the sclera. So we have all these options. So in cases of decentration and tilt, one can do the fixation by 3-point fixation with the needle going either through the lens material or around the capsule. So thank you very much for your very kind attention.